Yes.
Okay, so to get started with the session, I would request our moderator, Dr. Ranmini ma'am, to please start your presentation. Over to you, ma'am.
Ayubovan, good morning. I'm Dr. Ranmini Senivaratna, President of the College of Ophthalmologists of Sri Lanka. At the outset, I would like to thank Professor Mahipal Sachdev, the President, Professor Namrata Sharma, Honorary Secretary of the All India Ophthalmological Society, as well as the Organizing Committee of the 79th AOIC for inviting the College of Ophthalmologists of Sri Lanka to participate in this symposium. I must congratulate the Organizing Committee of the 79th conference for presenting a very, very excellent academic program. And indeed, we are privileged and honored to be a part of this program. Today, we have 6 expert ophthalmologists from our country with diverse interests to present their experiences to an audience, of a distinguished audience of the conference. And I'm sure they will make this symposium a very interesting one. To start off, I would like to introduce our first speaker, Dr. Ishanta Jayasekara. Dr. Ishanta Jayasekara, Consultant Pediatric Ophthalmologist of the Lady Ridgeway Hospital for Children, Colombo, which is the largest tertiary care center for pediatric cases. He is the Joint Secretary of the College of Ophthalmologists of Sri Lanka 2020 and 2021, and was a council member of the college in 2019. His special interest is in retinoblastoma, ROP, and pediatric glaucoma. He has published articles in peer-reviewed journals and presented papers at national and international conferences. Over to you, Hiranya, for your presentation on managing kids' needs unique ways.
Thank you, Ranmini. Thank you very much for this opportunity to present in this podium. Really feel privileged to be here. So my presentation is a basic one. My colleagues will present their very sophisticated surgical techniques. I will describe how we are trying to tackle ROP blindness and how we are trying to save more eyes in kids with retinoblastoma. In Sri Lanka, pediatric ophthalmology started in 2008. And up to now, there are 5 established pediatric ophthalmology units. Sri Lanka is a small country with only 22 million people, 350,000 live births every year with 10% premature. So we'll go to the first topic, ROP. As we know, ROP is a potentially blinding condition in very premature babies. So worldwide, intensive screening programs and evidence-based treatment protocols have led to reduced blindness, but still a large amount of babies become blind every day. But in Sri Lanka, blindness is extremely rare. So we found blindness, we already know blindness can be due to tractional retinal detachment, and we found that blindness can occur due to overtreatment as well. So both can be eradicated by using simple diagnostic approach. So how we treat ROP in that we classify them into 9 subgroups. So accordance with BEAT ROP study, we treat zone 1 ROP with intravitreal bevacizumab. IVB is intravitreal bevacizumab. So on 1 stage 3, even without plus disease, we treat with bevacizumab. Posterior zone 2 stage 3, also there's no question about it. We treat with intravitreal bevacizumab. If the ROP stage is more anterior, particularly if there's no very prominent plus disease, we treat with laser. So zone 2, stage 2 ROP is a gray area in ophthalmology literature, whether to treat or not. So we do treat posterior zone 2 stage 2 with plus disease, with intravitreal bevacizumab. But if the ROP stage is more anterior, more closer to the nasal aura, we don't treat, because most of these cases resolve spontaneously. Zone 3 stage 3 is another gray area, whether to treat or not, but we do treat to prevent other consequences like vitreous hemorrhage and tractional retinal detachment. So we treat zone 3 stage 3 with laser. We don't use bevacizumab in that situation. Stage 4A, invariably you have to do laser. Sometimes you might have to ask your retinal colleague to go ahead with the encircling buckle. So finally, recurrence ROP after intravitreal bevacizumab, I reclassify according to into one of these categories, previous categories, and treat accordingly. So it's a luxury if you can do the intravitreal injection in your theater with the facility of a operating microscope. But if the baby is too sick, too small to bring to the eye theater, we have to be used to go and give on the bedside. So we give the low dose, having the advantage of faster revascularization of the retina, and you are injecting a smaller volume into the tiny eye. We always inject under topical anesthesia, a restrained baby. Laser, of course, we do in the eye theater. We don't move the laser machine too much. And according to our protocols, the babies are bigger. The babies who need laser treatment are much bigger, so they can be brought to the eye theater without much problem. If the baby is tiny, then we do under topical anesthesia, but large baby, struggling baby, we do not hesitate to give general anesthesia. So we use the 532 nanometer green laser, the small spot size. So you can see here, we are treating more posterior disease with intravitreal bevacizumab, and there are recurrences, but the level of myopia is very low. This is the second year refraction. So the recurrences we treat, again, the posterior recurrences with bevacizumab injection, anterior recurrences with laser. So we preserve the option of laser mainly for more anterior disease, like zone 3 stage 3, stage 4A, and zone 2 stage 3. So again, there is some degree of myopia, but it is not very high. Only in a stage 4A cases where you have sometimes might have to put encircling buckle, the myopia is high. So blindness due to retinal detachment and excessive treatment can be eliminated in ROP. So retinoblastoma, next we move to the topic of retinoblastoma. We know it's the commonest intraocular solid tumor in children. In Sri Lanka, we find 20 to 25 cases every year. Unfortunately, majority of the cases, about 90% of the cases are either group E or D on presentation. And as a result of that, our enucleation rate is very high. So why such high enucleation rate? Mainly because of late presentation. And at the end of the treatment, standard treatment, we find too much vitreous seeds, too much solid tumor left to treat with. So we have to enucleate those sizes as well. So we thought of controlling those three factors to reduce the enucleation rate. So how did we get the referrals early? That's through education. Not only the general public, the professionals also. So there are a lot of myths and misconceptions about the squint and abnormal red reflex. So a lot of professionals think squint is not a bother. They tell the squint will disappear after 2 years. But they defer examination of a small baby with a squint. So how did we encounter that? Through newspaper articles, TV, television discussions, workshops, international collaborations. So a lot of work has been done to educate general public and the professionals, including pediatricians. So vitreous seeds is a major threat to the survival of the globe. And we found intravitreal chemotherapy is the appropriate way to save these globes. Presence of vitreous seeds not only scale up the diagnostic level, they also make the survival of the globe very difficult after treatment. So you can see you need more injections for certain cases, and it takes awfully long time to resolve. So we never use intravitreal chemotherapy as the first line therapy. Rather, we use it for recurrent and resistant vitreous seeds after standard treatment. We use two drugs, melphalan and topotecan. But unfortunately, melphalan is very unstable solution. Once you dissolve it, it becomes into, it breaks down very fast. So if you rely on your oncologist to deliver melphalan to your doorstep, you're too late. You will inject only water into patient's eyes. So we thought of reconstituting the drug in our own eye theater. So we started doing it, and the results are fantastic. So now we have become pharmacists who are reconstituting the drugs as well. So to manage a solid tumor, we found this excellent laser machine, infrared laser machine, which was donated by one of my patients. And within 1 year, we found we have saved a lot of globes with this powerful laser. So over the last 4 years, we found our enucleation rate of enucleation has gone down from 75% to nearly 63%. So we are in the process of getting down it even further low by introducing intraarterial chemotherapy. So pediatric ophthalmology is a difficult field. Not everybody will take up pediatric ophthalmology with a lot of interest, but it's very interesting. And a lot of developments can be made according to imagination and according to your needs. Thank you very much for your time.
Thank you, Chamira, for that very interesting talk. We will take up questions towards the end of the session after all the talks are over. And now for our next speaker, I would like to sorry about that. For our next speaker, I would like to introduce Dr. Chamira Bandara, consultant oculoplastic surgeon at the National Eye Hospital, Colombo, which is the largest tertiary center in the country. He was the Joint Secretary of the College of Ophthalmologists of Sri Lanka in 2019 and 2020, and he was a council member of the college in 2018. He has presented research papers and video presentations at national and international conferences, including the British Oculoplastic Society meeting, South Asian Endocrine Congress, and the ND8 Ophthalmology meeting of the UK, to name a few. He has published articles in peer-reviewed journals. His presentation today would be Pitfalls in Ptosis Management. Over to you, Chamira.
Thank you, Ranmini. Ayubowan, namaste. First of all, let me thank All India Ophthalmological Society. Can you hear me?
Yes, we can hear you, Chamira.
So, namaste. First of all, let me thank All India Ophthalmological Society for inviting me to do this presentation. We all know ptosis is a common oculoplastic problem. Even though its management looks simple and straightforward, journey for a successful outcome is always a challenging one. On this way, there can be many pitfalls where you can fall into and get into unexpected troubles. But if you are smart enough to identify these pitfalls in advance and avoid them, you can make sure the end results will never be an unpleasant one. So let's try to be familiarized with some of these pitfalls, the reason, and know how to avoid them. The ptosis management includes the diagnosis, decision on treatment, surgical procedures, and post-operative care. The pitfalls can be encountered in all 4 stages. Let's start with pitfalls in the stage of diagnosis. Going through a few cases, this lady came with a complaint of my right eye looks smaller for more than 1 year. So what is your observation? Yes, she got right brow ptosis. Unlike in facial nerve palsy, when you have a isolated brow palsy with particularly subtle ones, you can easily overlook. However, you can't afford to miss this. Make sure that you detect this. This lady again came with small right eye for about 8 months duration. There was no proptosis. So what could be the cause? This is how when the lid was everted and the biopsy confirmed marginal zone lymphoma. Again, this slide shows 3 similar cases. Ptosis coming with subconjunctival retention cyst, prolapsed orbital fracts, and conjunctival amyloidosis. So you must remember to evert the upper lid and examine the fornix in every ptosis patient. This 65-year-old female came with ptosis for 2 months duration. There was no proptosis, no upper lid fullness. The eye movements were normal. Since there was no significant clinical finding, but due to short history, we decided to image. The CT scan showed small soft tissue lesion in relation to the levator muscle, and the biopsy confirmed an inflammatory pathology. So remember, if you are in doubt in any ptosis patient, don't hesitate to image them. Again, this gentleman came with left upper lid ptosis for 1 year duration. So what could be the problem? Yes, it is floppy lid syndrome coming with ptosis. So you must make sure that you attend to the floppy lid before doing any ptosis surgery. Actually, this is the only case which is not from my clinic. I chose it after doing an internet search to give you an important message. So what is the cause for the small right eye in this lady? Yes, it is hemifacial spasm. This is how she was after Botox injection. So you must remember that hemifacial spasm can present with small eye, particularly it can be easily missed when the early stage where the lower part of the face may not be much involved, as well as when the patient is wearing a mask, particularly with current pandemic situation. This is an interesting case. This young boy came with right ptosis following a head trauma. Things that usually come to our mind are the third nerve palsy, levator dehiscence, or Horner syndrome. But when you see the image below, when the left eye is closed, the right eye ptosis gets completely reversed. When the both lids were open, he complained of double vision and the Hess chart said right superior oblique palsy. So what has actually happened here? The patient had subconsciously keep his right eye closed to get rid of the double vision. So this ptosis is a compensatory ptosis. So you must make it a point to cover the other eye and examine in all cases of unilateral ptosis. This thyrotoxic lady came with right droopy eye, no proptosis, eye movements normal. We thought about myasthenia gravis. We did all the investigation, but all negative. So we went again for imaging. The CT scan showed enlarged levator superior rectus complex in the left side where there's no ptosis. So how are you going to explain right eye ptosis in this patient? It's like this. Because of the left levator inflammation, it leads to subtle lid retraction, and this in turn leads to less innervation to levator muscles. According to Herring's law, there will be less nerves torn to the right levator leading to right ptosis. So remember the Herring's law, paired eye muscle receive equal innervation. Again, this patient had right ptosis with lid retraction. So what is the possibility? So it can be right ptosis with Herring lid retraction in the left eye, or it can be the vice versa. But if you look very carefully, what he has is lateral canthal dehiscence. leading to lid retraction and short palpable fissure. So before doing any ptosis surgery, you have to fix the lateral canthal and examine for the new lid positions. Coming for the pitfalls in the stage of choosing treatments, this 14-year-old boy came with a ptosis following a dog bite, which occurred 7 years back. He had poor levator function and had 7 brow suspension without lid position improvement. So can you understand the problem? Because of the dog bite, the frontal branch of the facial nerve has got injured, causing left frontalis muscles to paralyze. So how come? Then obviously paralyzed frontalis can't lift the lid. So it is important to remember and check for the brow function before doing brow suspension. This lady again came with levator function for 12 months in both eyes. So what is your treatment plan? When you look, you can see the both brows are overacting as a compensatory mechanism. But despite that, he has not only the right, there's a left mild ptosis. So if you correct only the right eye, it is sure that the left lid will fall down when the compensation ceases. So you must do bilateral levator surgery in this patient. So remember this kind of latent ptosis and you should not miss it. This girl had right ptosis with lower lid retraction. So if you correct only the right upper lid, definitely she will have a very wide eye, which will give you a cosmetic problem as well as the risk of exposure. So you should not overlook lower lid retraction and should correct before doing ptosis surgery. Coming to the pitfalls which happen during the ptosis surgery. So usually we target a lid position which is in the range of 1 millimeter from the limbus, superior limbus. However, we can't keep the same target in all patients. In that case, we can fall into trouble. For example, this lady with Kern cell syndrome had bilateral ptosis with external ophthalmoplegia. She also had poor bells. Because of that, we could not compromise her lid closure. So we did only a partial correction of ptosis. So the visual axis is clear and at the same time lid closure is preserved. Remember, safety is more important. Again, ptosis surgery is a cosmetic procedure. The overall look at the end of the procedure is what makes the patient satisfied. So these two patients had right levator surgery and has very good lid height and a shape. But if you see, the two lids are asymmetric. The contour is different and they are not alike. So what we usually think is making a lid crease incision identical to the other eye give you a post-op symmetry, but that is a wrong understanding. If you look at these two patients who underwent left levator surgery, has very good lid contour with symmetrical pretarsal show, brow fat span, and lid skin fold. This kind of aesthetic finish can be achieved only by contouring residual lid skin, preaperonotic fat, descended roof fat, and the septum. Remember, this will not depend on lid crease incision alone. Coming to the last part of the topic, pitfalls in the post-operative care. This lady with right ptosis came 4 weeks after the surgery saying, "Doctor, my lid swelling has gone, but my is still small." So what do you think I did? Well, I did nothing. I waited for another 2 months, and this is how she was after that. So remember that you should not rush for any correction, post-op under correction, post-op under or over correction. So it is important to wait for 3 months before doing any touch-ups. Same way, this patient had bilateral levator surgery, and her eyes were not very perfect. Again, we waited for 4 months, and this is how she was at the end. So believe me, waiting is a very good management option during the post-op period. This girl had the right brow suspension but has residual ptosis. So what do you want to do? Do you want to go and redo and augment it? See, that her lid frontalis muscle. So what she has to do is practice to use the frontalis muscles to get the lid lift. And this is again, patient had bilateral levator advancement and she was not happy about her left eye. Again, I covered the right eye, left eye was perfectly okay. So what's the problem here again? So the patient has had uncorrected exotropia, giving rise to the impression of residual ptosis. So remember, not only the vertical strabismus, even the horizontal strabismus need to be corrected before ptosis surgery for a better cosmetic outcome. And this is the final case. This patient had right ptosis and operated by a plastic surgeon, came to me claiming right eye is too wide and ugly. In fact, the plastic surgeon has offered her to revise the surgery. Can you guess what I did? I did left side levator advancement, and this was the post-op appearance, and she was happy. So what has happened is she has had left latent ptosis, and which has got apparent after the right eye ptosis. So compensation has shifted from right to left, giving rise to the innervation, nerve innervation to both eyes, which is got aggravated, leading to right lid retraction. So the take-home message, so beware of brow ptosis, examine underlid and the foci lids, facial spasm, do imaging if no obvious cause, think about Herring's law in all stages, check brow function before brow suspension, don't overlook compensated ptosis, correct lower lid retraction and squints before ptosis surgery, ensure safety before aesthetic look, manage pre-tarsal show and the brow fat span for better post-op look, and don't rush for post-op touch-ups. One final word, your patient may be having limited visual field due to ptosis, but as the treating clinician, you can't afford to have a limited view. So I hope this presentation helped you to have a wider view toward the ptosis management so you can go a safe journey without falling into pitfalls. Thank you very much.
Thank you, Chamira, for that very interesting and informative talk. Our next speaker would be Our next speaker is Dr. Ishanta Jayasekara, consultant in cornea and external eye diseases of the National Hospital, Kandy, which is also a tertiary center. He is a council member of the College of Ophthalmologists of Sri Lanka, 2020 and 2021. He has presented research papers at national and international conferences, including VACRS, and had been a guest speaker at the UK ICSCRS. His presentation today would be surgical management tips on PUK and how to manage a decimal structure while preparing for Dsec. Over to you, Dr. Jayasekara.
Thank you, Dr. Ranmini. Just waiting for the screen share. Hello, good morning, and sorry for the delay, just getting up the slides in place. I would like to thank the All India Ophthalmology Society and the College of Ophthalmologists for giving me this opportunity to speak on surgical management tips on peripheral ulcerative keratitis. As you know, peripheral ulcerative keratitis is a destructive inflammatory disease of the juxtalingual corneal stroma that is associated with epithelial defects, presence of inflammatory cells in the stroma, and progressive stromal melting. It could be associated with various ocular as well as systemic infectious and non-infectious diseases.
Sir,
The
please
basic
share full screen mode, sir.
Sorry to interrupt you, sir, but your the presentation is not in a full screen. We can see different slides at the same time. Could you please make your screen full?
Yes, sir. Yes, sir. Okay, thank you.
Yes, sir. Now the screen is completely visible.
Okay, so basically the pathophysiology is there is an imbalance between the levels of specific matrix metaproteinases and tissue inhibitors in peripheral keratitis, and this is the reason for the rapid keratolysis, which is a hallmark feature of the condition. And corneal fibroblasts, the keratocytes, play a crucial role in it. So when we see there is involvement of the adjacent structures like conjunctiva, episclera, and scleral inflammation, and with timely diagnosis, detection of the underlying systemic inflammatory disease, and proper treatment, we can treat PUK and its involved sequelae. Usually, the patient will present with redness, pain, watering, and photophobia, and pain is a prominent feature and it may be severe. And any excruciating pain out of proportion to the severity of ulcer is often a characteristic feature of Murren's ulcer. The decreased vision can be a late presentation because sometimes the patient may have normal or subnormal vision, but long-standing cases, the reduced vision may be due to induced astigmatism, corneal opacities, or treatment side effects like cataracts and glaucoma. And also patient can present acutely if there is corneal perforations due to the thinning of the cornea. There can be many systemic manifestations of the PUK, and there can be also occult systemic diseases. And a thorough systemic history is very important to find out the cause of the disease. Because it's associated with a large number of diseases, it is very important to diagnose etiology in peripheral ulcerative keratitis, and most often you can find an etiological cause. Like I said, these are the various diseases. So there can be inflammatory diseases, infections, ocular surface instabilities, and limbal stem cell deficiencies. There's a crescentic ulceration with an epithelial defect and thinning of the stromal infiltrate at the limbus, and it begins as a crescent-shaped white infiltrate. So you can have an overhanging edge with stromal loss and thinning and adjacent stromal infiltrates. So this is a patient who presented with thinning of the cornea and melting with an iris plug at the perforation site. So Murren's ulcer is an ulcer of exclusion, diagnosis of exclusion made in case of PUK without any systemic association or without scleritis. So how do you differentiate PUK with the Murren's ulcer? Pain is not severe as in Murren's ulcer. The extension into sclera may occur in PUK, and there is no separation between the ulcerative process and the limbus. It is always important to exclude any infective cause before you start treatment with steroids in PUK, because if you start with steroids and without any microbial treatment, then you can aggravate the situation. How do you know this is due to infective cause? It is, so usually you have a trauma history with vegetarian matter, history of contact use, or past history of viral keratitis. The main goals are to ensure quick healing of the ulcer with minimum sequelae and to avoid recurrences. So there should be a balance between the medical therapy, local and systemic surgical intervention, and usually a multidisciplinary approach is usually needed for treatment of these patients. If we come into surgical management, earlier we used to use large grafts, because even for smaller decentered or extra central grafts, because we had no other options. But these were prone to increase the chance of vascularization, peripheral anterior synecdoche, and anterior chamber and graft failure. So what are the treatment options? We usually do a conjunctival resection, because we need to remove the limbal source, because it is thought that the vasculature causes the interactions and brings the infective foci, the inflammatory foci, and it also may be of a diagnostic help. We can use tissue adhesives with glue, patch grafts, which we use now, superior lamellar keratectomies for any opacities in the anterior cornea, and conjunctival flaps. But conjunctival flaps should be used judicially, because they can incite, bring in the causing agent and cause more inflammation. We have a match and patch technique, where we match the patch the host, which is the defect to the host, and then we graft the needed area. If you can see, this is the cornea, and we can match the area. So this is the graph that is there. We can match the area and patch to that graph. So if you can go into the video. So this is a patient who had an extensive peripheral artery keratitis. It is always important to find the exact margins before you go in for the treatment and grafting. What I usually do is I usually get about 0.5 to 0.75 excess to the edges, because very important that when you do the grafting, you should have a healthy donor site for the sutures to take adequate biting. Then with a marked trephine, you can get the margins of the thinned out area. And it's very important not to give in a lot of pressure, because this can perforate the cornea. And then with minute manipulation, you can get the edge of the cornea and make sure that you have separated all the synecdoche using viscoelastics on and an iris depositor, so that you don't inadvertently catch the iris. After the cornea has been excised, it is very important to separate all the synecdoche which is attached. You can use either BSS or methacellose, and it is very important you remove all these additions, because if the additions are not removed, these can cause further problems later on. Again, I take about 0.5 to 0.75 excess to the margins of the donor area, because that will help us to give in tighter sutures, avoiding gross astigmatisms. You follow the basic suturing techniques for the grafting, making sure that you have adequate bites in both the donor and the recipient. And at the end of the surgery, make sure that the cornea, the eye is airtight with no leaks. So this is the patient who had a peripheral melt, a C-shaped, banana-shaped melt. And it is important because most of them have the iris has been out for a long time. So make sure that the additions are removed before you start the suturing. It is always important to remove all the additions between the cornea and the iris. So because this was a relatively smaller patch, I thought I can get the donor cornea by putting it over the melt. So what I did here was I took the cornea, and with corneal markers, you can get the exact measurements that are needed, and always make sure that you get it slightly larger than the actual defect. Because if you have a same size graft or a smaller one, later on when you try to suture it, you will have quite a large astigmatism. And always, like I said before, make sure that the edges that you have to graft are all have a relative thickness, so that you won't have any cheese wiring. And after the grafting, you can make sure I usually instill an air bubble into the antechamber to know that the grafting is okay and there are no AC leaks. So what are the post-op considerations? You have to continue treating the underlying diseases, management of the grafts with reducing inflammation and to prevent graft rejection. It is very important to manage the ocular surface with lubricants because they usually have quite severe dry eye conditions also, and also they can have Delan formation and visually rehabilitation and time suture. So in conclusion of this first talk, so the potential PUK is a potentially blinding disease and it's considered most of therapy, but with proper management and multi-disciplinary approach, you can manage them safely. Surgical therapy, although technically challenging, can give better prognosis in all stages of the disease. This is a small presentation on what to do when you have descemal rupture while you are preparing for a Dsec. So basically, this is the evaluation of Dsec. We initially had penetrating keratoplastic, then it went on to deep lamellar endothelial keratoplastic, which was quite daunting task to do. Then we had Dsec and D6, and then DMEX or descemal membrane endothelial keratoplasty. What are the indications we have for bullous keratopathy, Fuchs dystrophy, failed PKs or Dsec, eye syndrome, toxic anti-segment syndromes, and congenital hazy endothelial dystrophy. So why do we usually do endothelial grafts in case of full penetrating keratoplasty? The visual rehabilitation is rapid. There are no suture-related problems, less astigmatism, the graft, the eye is stable, no ocular surface problems. We have fewer rejections and small incision with less risk of suprachoroidal hemorrhages. So if you can see, usually what I do is I have a marked refine of about 350 micrometers, which I go in, and then with the crescent knife, I get the initial incision to get the cleavage plane. And with the blunt dissector, I go in with the dissector. If you have an anti-segment OCD, this is very convenient, so you know the exact depth, but unfortunately, when you don't have it, you have to rely on depth, and you can see it perforates here. So without discarding this eye, what you can do is you can suture the initial site that you made the incision, and always make sure that the antechamber, the pressure is not tight, it should be slightly less tightened, and then from another side you can go in, and I have put in an air bubble so that I know exactly at which plane that I'm going now, and always make sure that you dissect the perforated part where the suture is at the last.
Sorry to interrupt you, sir, but your time is finished. So, and
Right.
we are running out of time. Could you please sum it
so,
up? Yeah.
Yes. Okay. So this is the end. Okay. So this is a post-op patient. Right. Thank you.
Thank you so much, sir.
Thank you, Dr. Jayasekara, for that interesting talk. Our next speaker would be Dr. E. Sriharanathan. Let me share my screen with you. Right. Dr. Sriharanathan is a consultant vitreoretinal surgeon, also of the National Eye Hospital, Kandy, and he's a council member of the College of Ophthalmologists of Sri Lanka 2020 and 2021. He's a former ICU fellow at New York Eye and Infirmary. His special interests are in diabetic retinopathy, macular hole surgery, and ROP. He is an examiner for postgraduate examinations in ophthalmology at the Postgraduate Institute of Medicine, Sri Lanka, and he has research paper presentations at national and international conferences. His presentation today would be My Preferred Technique in MIVS. Over to you, Dr. Sriharanathan.
Thank you, Ranmini, for that kind introduction. First of all, I would like to thank all Indian ophthalmology members who have given chance to give opportunity to present this small talk. And I will talk about you with regarding my preferred techniques in micro-incision vitrectomy surgeries. Right. This is my mighty island. In the center of the island is called Kandy, where I work and operate. It's the last capital of Sri Lanka in the era of kingdom, king's era, and now it's famous for tourism. This is a hospital, is second national eye hospital in Sri Lanka. It's located in the center of the city, surrounded by mountains. And this is a center for sight. It's a part of this hospital is located one corner where I work and operate. So this is my workspace. It's not very hi-fi equipped. We have a basic instrument like Lumira microscope and Resight wide-angle viewing system. And we get consumables and other instruments from the state government. So we don't get everything regularly. So we make adjustment to maintain the situation comfortably by making some adjustments. So this is a machine I was offered from the hospital, and I don't have any commercial interest on this machine. It's an Alcon Constellation machine, which is, I compare this with it's a monster, which has lots of function. We usually forget to utilize some of its functions. So I would like to highlight a few things during this talk. So the first condition I should talk is, first of all, I would tell you about the vitrector, which is not only is remove the vitreous, but also it can be converted as a membrane dissector, or it can be converted to flusher, can be converted to scissor, clot remover, and sometimes I use as a foreign body forceps. How? It's by changing its parameters. So these settings are not in the default in the machine. We need to harness that machine to get the things out of it. So first condition, we are surgeons encounter everyday surgical session. In our population, around 20 to 30% are diabetics, and in our clinics are flooded with late stage proliferative diabetic retinopathy. And it's it's a nightmare for a VR surgeon when it encounters in a late stage. So how I manage in my day-to-day practice in these late stage advanced PDRs, first of all, I preoperatively prepare them very carefully by optimizing their systemic status. Is mainly, first question I ask them is how is their blood sugar control, blood pressure control. That if they don't have, I will send them for proper place to make optimize their systems. And in the meantime, I prepare them mentally, prepare them for multiple surgeries and possible outcomes, and this should be well before inform them. And I usually motivate them for self-management of diabetes unless they take care of their diabetes, our surgery won't be successful. I emphasize that very carefully to them. And I arrange them good pan-retinal photocoagulation, which makes my surgery comfortable, and surgical outcome will be better if you have a good PRP done. And pre-op anti-VEGF treatment is my preferred technique, which makes my surgery more easier, and by making the surgical field clear and less bleeding, and it prevents from making iatrogenic breaks, and post-operative visual outcome is better when we use preoperative anti-VEGF. During the surgery, intraoperatively, I tune my monster in a way it converts it as a scissor. By it can be the cutter vitrector can be converted into scissor by reducing vacuum to 40 millimeter mercury, and the cutting rate between 100 to 200. The cutter automatically it function as a scissor. It can be converted as a flusher by exploiting micro influx mechanism which is in the machine, and it can be converted into dense clot remover by using its momentary cutting mode, and use the shaving mode to shave the vitreous. And in the meantime, the foot switch of this machine has 4 small switches, 2 front cradles and 2 heel switches, which each switch can function as 2 functions. Altogether, you can assign 8 functions. So most of the time, you don't need to rely on your assisting nurse. If you assign those functions into the foot switch, then you can be independent of more independent most of the time. And recently, last 2 years, I prefer 27 gauge bevel vitrector because the shape and the design is very elegantly prepared for scar tissue dissections, mainly in proliferative diabetic retinopathy surgery. And I use perfluorine in early stage of these surgeries because it provides some tamponade over the disc, which prevents the bleeding. In the meantime, it protects the macula from clots occupying the macula. Otherwise, if the clot occupied in the macula in late stage, it's very difficult to remove, and it will end up in macular breaks. In the meantime, I prefer illuminated laser, chandelier light. Those are very useful accessories in this surgery, which makes me more visible environment. Also, I use triamcinolone, and end of the surgery, I use anti-VEGF, which also helpful to get a good visual outcome in the late surgery. So it's one of the surgery I done for PDR. And I use the 27 gauge vitrectomy system, and you can see there's a traction of the macula, and you can see striae of the macula. I use the triamcinolone to stain the vitreous and delineate the thick posterior hyaloid membrane. This thick posterior hyaloid membrane need to be removed carefully in these proliferative cases. Otherwise, if you leave them vitreous over the macula, you will not succeed in this surgery. And I use Trifan blue or brilliant blue to stain the internal limiting membrane, and I peeled in this case because there was macular traction. And I use perfluorine in early stage here, which will prevent further bleeding, and it will give a tamponade over the disc, and it prevent the macula to be occupied with the blood clot. And during the fluid exchange, I start fluid exchange in the early stage, which also gives some tamponade effect, and I use a illuminated laser to laser the periphery, which will prevent late stage neovascular glaucomas. And another condition which we are surgeon encounter in the clinic is refractory macular hole. Usually most macular hole close 90%, 95% of the macular hole close in first surgery, but there are some which give headache in your life. So this is a new technique which described last few years, and I started using this platelet-rich growth factor, which can be prepared from the hematology lab. It's not very expensive. It can be prepared from the patient's own blood. It takes a few 1 hour, and I realize with my hematology people, and they prepare it 1 hour before surgery. And this is one of the case of I did this platelet-rich growth factor. He's a 70 years old man, came with macular hole. It's a little larger hole, but I did a routine macular hole surgery, and it was flawless, and it ended up in unclosed, and at the meantime there are some subretinal fluid developed over the macula. So now I am forced to do a second surgery to get this problem out. This is a pre-op and the post-op OCT. The post-op, you can see still macula is not closed. So this is a 27 gauge vitrectomy done, and I use the perfluorine in the early stage because it's bullousness, and I didn't drain the fluid through the macula. I made an extra drainage retinotomy and drained the fluid. Then here, since 27 gauge is very small opening, so I have to convert this into 23. This is a platelet-rich growth factor, which I take from, it's prepared from patient's own blood, and it was sent into the vitreous cavity, and I mobilize this piece with the use of Tainer brusher, which is blunt now because I have repeatedly used several times. There is no diamond at all, so now it's a blunt, and so you can fix that platelet growth factor as a, it's like a gel, like a stiff, and it's easy to fix it into the hole. And this was a pre-op picture and the post-op. So it's a timeout. Okay, this is a post-op picture of this case, and it is well closed. So this other one. It is if you can't find the hole, what you can do. This is you can do exploit triamcinolone blue to inject subretinally, and you can find this area. You can find it is coming out through the unseen hole. So you can find the break, and after that you can seal it. So it's my take-home message is understanding your available retinal toolbox in your operating room, which makes you a dynamic VR surgeon. Thank you very much for listening.
Thank you, Dr. Sriharanathan. Now to move towards our next speaker. Let me. Right, our next speaker would be Dr. J.G. Mahesh, who is a consultant ophthalmologist, general ophthalmologist from the Colombo North Teaching Hospital, and he's the recipient of the Presidential Research Award, National Science Foundation, Ministry of Science and Technology, Sri Lanka. He has obtained his fellowship from the Cardiff Eye Unit at the University Hospital of Wales, UK, and has many publications in peer-reviewed journals to his credit. He's also a winner of the seven national level research awards. His presentation today would be tips for tucking intrascleral haptic fixation. To you, Dr. Jayavira.
Thank you, Madam President. Good morning, everyone. First of all, I want to express my sincere gratitude to the AIOC organizing committee for letting us this wonderful opportunity. Tips for tucking. During my talk, I wish to share my experience and some useful surgical tips in intrascleral haptic fixation using the modified flange haptic technique, which is a modified Yamane technique. We as eye surgeons do really well with regard to our cataract surgeries, achieving one of the most successful surgeries in the world out of all the surgeries. And however, things can go wrong very rarely, sometimes may end up in losing the capsular bag support. IOL placement in the absence of adequate capsular bag support. There has been many techniques described as in the anterior chamber IOLs, iris fixation of IOLs, scleral fixation with sutures, and intrascleral haptic fixation techniques. Out of those, intrascleral haptic fixation is a preferred and becoming more and more popular, which is a sutureless technique. There have been many methods described as in blue IOL technique described by Amar Agarwal, and IOL tucking into the scleral canal as in Gabos technique, and double needle flange haptic technique as originally described by Shin Yamane. So following videos, I am showing my way of doing this intrascleral haptic fixation using the modified flange haptics. This is all what I needed: a corneal marker and a marker pen, anterior chamber maintainer, a caliper, 2 microholding forceps, and a hot pointer, 26 or 27 gauge needle. As you can see, this can be done relatively in a low resource setup. This is of a 74-year-old female who has phaco only done some time back and defaulted. Subsequently, she consented for a secondary IOL, and she had a aphakic refraction of 612. All these surgeries were done under topical and subtenon anesthesia. The first step is to make the corneal marking 180 degrees apart, and my preferred positions are 2 o'clock and 8 o'clock position, as you can see here. And then mark the site of the scleral entry 2 millimeters away from limbus and 2 millimeters parallel to the limbus. While marking, make sure that you make these markings along with the direction of the haptics, so that it will be easy for externalizing the haptics. After that, I'm making anterior chamber parasynthesis using 1.2 slit knife. This is for the anterior chamber maintainer, and the other 2 are for my microholding forceps. After fixing the anterior chamber maintainer, after fixing this anterior chamber maintainer, I'm making my main incision with a 2.6 millimeter slit knife, and I'm using this multi-piece foldable intraocular lenses. In this situation, this is a sensor multi-piece lens. This is the scleral entry. As you can see, I'm going parallel to the limbus, making sure that I'm getting at least 2 millimeters of scleral tunnel before I enter into the anterior chamber. And then my assistant is holding and fixing the needle in position. I'm going to insert the intraocular lens, inject it so that the leading haptic will leave on the iris and the trailing haptic leaving outside. It is quite important to leave the trailing haptic outside rather than delivering the entire lens into the anterior chamber in the first instance. After doing that, with my microholding forceps, I am feeding the leading haptic into the lumen of the needle. So you can see here the direction is in favor of the needle lumen, and slowly externalize the haptics, and then hold it with the microholding forceps, and then flange the haptic using the hot pointer, making sure not to touch the tip of the haptic. You can see there's a nice smooth bulb there. After fixing the leading haptic, I'm inserting the needle for the trailing haptic there. Again, through a similar 2 millimeter scleral tunnel, and then enter into the anterior chamber. And my assistant is holding the stabilizing the needle there. I'm internalizing the trailing haptic using my 2 micro holding forceps in a handshake manner, so that the tip of the trailing haptic is in favor with the direction of the needle there. As you can see, the direction of the haptic is in favor of the needle, and after feeding it into the lumen, I'm slowly externalizing it and flanging in a similar manner, making sure not to touch the tip of the haptic. Thereafter, doing flanging, I'm tucking these 2 ends into the scleral tunnel and covered with conjunctiva, and all the wounds are hydrated. So at the end of the surgery, in this case, although the pupil remain eccentric, the IOL will remain centric and stable. So few tips: make sure to make the corneal marking 180 degrees apart to avoid IOL decentration. And my preferred positions are 2 o'clock and 8 o'clock positions. And make the scleral entry 2 millimeters from the limbus and through a 2 millimeter scleral canal to avoid IOL tilting and dislodging. And direction of the tunnel should be in line with the haptic direction. Always use a AC maintainer to avoid intraoperative hypotony and bleeding. If it bleeds, that will obscure the visualization and surgery will be really difficult. And needle pass through at least 2 millimeter scleral tunnel, not straight in, to avoid dislodging and tilting of the IOL. Leading haptic first delivered into the iris and trailing haptic delivered outside. And trailing haptic internalized with double-handed technique, making sure that the haptic direction is in favor in the feeding into the needle. And do not touch the haptic when flanging to get a nice smooth flange. Otherwise, if it touches, it can cause an irregular flange, which can later erode through the conjunctiva. This is a process of haptic feeding, externalizing and flanging. Then I'm going through a scleral tunnel and feeding the haptic there. That is the leading haptic, feeding it slowly and externalizing. And then flanging as described earlier to get a nice smooth bulb there. And if sometimes this is one of my early videos, I have delivered the trailing haptic into the anterior chamber straight away, but you will find that for it to feed into the needle, the haptic direction is not in favor of the direction of the lumen. So you will have to struggle to feed this haptic into the needle. So now I'm not delivering it straight away. I'm delivering the haptic outside, trailing haptic outside initially. And sometimes haptic can break. This is one of my cases where after fixing the leading haptic, the trailing haptic broke there. While try to feed it into the needle, there you are. But the remaining part I have fed and externalized and flanged. And then what I did was I cut a similar portion of the leading haptic and flanged it again, so that the entire IOL remains centered, so that you can do adjustments in the IOL centration in these surgeries. And this can be done even after ECC only or lensectomy procedures. As in this case, where you can go through a relatively smaller incision in a similar technique, giving better postoperative outcome. So externalizing and flanging the both haptics. Intrascleral haptic fixation using modified flange haptic is becoming more and more popular because it has less surgical steps and compared to the other method of haptic fixations, and therefore it is less time consuming. It can be done through a smaller sclerostomy 26 gauge or 27 gauge needle as in our setup, or if you have ultra thin needle, you can go up to 30 gauge needles when compared to the 23 gauge or 21 gauge incisions in other techniques of haptic fixation. Therefore, it imposes less risk of post-operative hypotony and infections, and you can get a stable and centered IOL. Of course, you can adjust the centration as well. As in all other techniques, there is a learning curve, but it's really worth going through. Thank you very much.
Thank you, Dr. Mahesh, for that excellent talk. Our last speaker for today is Dr. Ishanta Jayasekara. Let me introduce Dr. Pires. Dr. Ishanta Jayasekara is a consultant ophthalmologist, a general ophthalmologist from Teaching Hospital, Rathapula. He is an examiner for postgraduate examinations in ophthalmology at the Postgraduate Institutes of Medicine, Sri Lanka. He is a lecturer for postgraduate trainees in ophthalmology. His special interests, being a general ophthalmologist, include cataract surgery, secondary IOL implantation, and also vitreoretinal surgery. He is involved in performing cataract surgery at cataract surgery programs in remote areas in the country, thus serving the community. He has presented research papers and videos at national and international conferences. His presentation today would be a buffet for aphakia with no capsular support, scleral fixation of IOLs. Over to you, Dr. Pires.
Thank you, Madam President. So I think Mahesh did a lot of explanation that I also plan to do. Now, capsular insufficiency is a common, not so uncommon thing that can hinder our results. So there's an inadequacy is not that much. Of course, we can do a gentle phaco, slow phaco, and then go in and put a CTR if possible. And this will keep the stability of the remaining capsule intact, and then you can put a preferably 3-piece lens and you can get away with it. So, but it's not always the case. It's not always the case. Sometimes you end up with, or you encounter rather, bigger capsular deficiencies where you have to go and do operate in a different way. So, Vanakkam and Namaste, India. Thank you for inviting us for this meeting. So, our talk would be on aphakia, how to get aphakia when there's no capsular support. So, as Mahesh also said, there are so many ways of doing this. So, in a 3-piece IOL, of course, you can have the Gabo, Agarwal, and Yamani techniques, and sometimes you don't have that option. The patient can't afford, and then you have to do with what you have. So, in such situations, you may have to suture the existing IOL into the sclera in the conventional way. So, I usually use both techniques. Now, if you take the classical scleral fixation, we make a flap on both sides, then pass the needle and put a suture, 10-knot rolling, and suture the haptics. So, Dr. Hoffman presented a case in ACRS where you can do transconjunctival limbal incision and go backwards, go outwards and make 2 pockets without entering into the sclera via conjunctiva. So, our motive is to go for less suture, less opening, and less AC turbulence. So, with that in mind, this is something that I sometimes do. So, 180 degrees away or apart, we make 2 scleral pockets through the limbus. I have sped up the video for brevity. Then we pass straight 10-knot rolling needle and retrieve it from the other side using a 27 or 26 gauge needle and maintain the parallel direction. We again reduce and take it from the other side again. So now you have now 2 lines of sutures inside, which strengthens the procedure or the lens, then you divide it, take one haptic out and suture. So this is a single piece IOL, but usually 1 or 2 sutures would be enough. It will not slip usually. Then you take it inside or you put it inside and take the other haptic out gently. So here I usually don't use many AC method. I try to do the whole surgery with cohesive viscoelastics. Then you rotate the IOL into the place, then retrieve the sutures from the pockets and suture. Gentle suturing is enough. You don't have to do tight suturing. And here we might have to stitch the pockets with one single suture on either side and maybe a suture at the entry point over where we took the haptic out. But you can even leave it without suturing if there's no much of a astigmatism that you can demonstrate. So, but as Mahesh also showed that the trend is to go more and more sutureless. So the idea is that you put a 3-piece in, delivering one haptic into the entry chamber or to the iris, and using a MST forceps or a catch forceps, micro forceps, you secure it. Then that's the leading haptic. Using another needle, similar. Usually what they recommend is a 30 gauge TSK needle, wide bore, which we don't have in Sri Lanka. And then thread that also, and then simultaneously take them out. And you get a very quick surgery done with least amount of manipulation. So then you make the flange and then rotate back the haptic so that they are not exposed to the outside. So the rationale here is that you go from limbus radially out 2 millimeters away and then gradually enter into the sulcus, respecting these wound positions. So you have the entry wound and the needle entry points are 90 degrees away. And when you go in from the 2 millimeter side, you go gradually at an angle of 20 degrees as you go in with a 5 to 10 degree inclination or declination inside. Nowadays, there's the goiter, no financial interest. They have made this simple by making a needle marker where all are set in. So the 2 millimeter mark, and there's a groove to send the needle in. Everything is repeatable. And once you place it properly at the limbus, centered, you can just pass a needle through the groove that has been prepared, and we will end up with a very symmetrical result. Now, what we do in Sri Lanka, we don't have those. So here is a patient where the traumatic cataract, traumatic cut cornea sutured and sent to me by a colleague. So I usually use 27 gauge needle. It's a long needle. I bend it so that will be more manipulation is much easier. I usually pre-place the needles. My idea with my is to have the least amount of AC disturbance. So I will go with a 2 millimeter tunnel and then sink in and then retract it and keep it there. And do the same thing on the other side as well. So you gauge where the needle went. I usually don't mark because it's not always, you don't end up where you mark. So there's no point marking usually. And then you do the same thing. And deliver the needle and retract a little bit to prevent hemorrhage and keep it there. So when we do the surgery, we have to be careful that the needles will not bubble here and there. So there's another additional thing that will keep your movements in check, that you will not do too many acrobatics inside. So now the needles are in place. Then I will introduce the lens, and I usually use cohesive viscoelastic in favor of AC maintainer. Then same here, I think all these techniques will have the leading haptic delivered onto the iris. Then keep the trailing haptic outside, and then feed the leading haptic onto the needle. There are some who will keep the lens in the cartridge and deliver, and then use the assistant and then deliver the leading haptics at the same time without delivering the whole thing into the antechamber also. So usually relatively this is not difficult, but it's very easy if we fill the needle with BSS. And very rarely I have seen that all these needles are not of the same quality. You might have to trim the edge like so that it will go very easily inside. And then you rotate it a little bit and then introduce the trailing haptic inside now. This is the most difficult part of the lens. That's the procedure or the most challenging part. The lot of kinking, bending, and breaking can occur. So be very gentle with this. And again, the Alcon 3 piece, I find very flexible. It's very easy. But AR40 is not so flexible, but it's very long. So the haptics are long, so you have some room for manipulation there. So both has their advantages and disadvantages. See, it's gently goes in. Another thing that you can do is for the leading haptic, you can use a 27 gauge needle, and for the trailing haptic, a 26 needle, because it works quite fine. Then the classical Yamini technique, you can retrieve the needles simultaneously at the same time. And what I find is that once you take it out, tease out, you can use a suture tiny to hold the end of the haptic, and then cauterize and create the flange. Yeah. Once that's been done, we can retrieve the other side as well and follow the same thing and create a flange. So once you made one side, usually it does not slip usually, but flange is important for something else to maintain the refractive stability. So it's almost done. Then I might have to do a little bit of vitrectomy and clear the viscoelastic that I have put for the procedure. In these surgeries, sometimes crocodile shattering could be quite a problem, and even arcus senilis, because the visualization becomes quite an issue there. You might have to use a lot of viscoelastic on top of the cornea to maintain the clarity. Undilated tubules are not a big issue. The other way of retrieve the haptic would be the sequential delivery, not the simultaneous. You take one as mine showed. That's also quite safe, I should say. You then make the flange, and when you make put the trailing haptic, you might have to get the haptic a little bit out, so it will create more room for the manipulation. And here, this is our flange. We don't have cautery, so this is what with the Bunsen burner, we heat and do this. Now, the new advances would be in Yamini technique would be to get a perfect target emmetropia. So, if you have a on-time way of checking the refraction, what you can do is to adjust it and cut the haptics on both sides. So, what happens is when we rotate the haptics in, it will become more myopic. As you read outside, be hypermetropic. So you can come to in-between situation where you get a perfect refraction and then cut and suture. So we all learn this by doing trial and error. It's a good thing to practice and find what works you for best. Thank you. Thank you, India, again for incorporating us in your wonderful sessions.
Thank you, Dr. Ishanta. Now it's the session for question and answers. We have a few minutes for questions from the audience. If there are any questions, we are happy to take up. In the absence of questions, I would like to round up the symposium today. It was a very colorful symposium with a variety of discussing variety of topics and excellent talks. First speaker, Dr. Jayasekara, discussed treatment modalities, followed by him to manage ROP effectively and his experiences in management of retinoblastoma towards reducing the rate of enucleation. Second speaker, Dr. Chamira Bandara, showed us how to identify and avoid unexpected problems or pitfalls in dealing with management of ptosis during diagnosis, during surgery, and during post-operative care. The lecture involved great facts and to keep in mind to avoid unnecessary complications when dealing with this disease situation. Dr. Ishanta Jayasekara, consultant surgeon in cornea and external eye diseases, presented a very interesting talk on pathophysiology and causes of PUK, including a video to show how to handle this problem surgically effectively. Dr. Sridharanathan gave a detailed account of the ways of managing diabetic retinopathy, including preoperative care and per-operative techniques mastered by him for a better outcome. The last two speakers involved, as all of us as cataract surgeons encounter problems of inserting an intraocular lens when there is inadequacy of capsular support. So the last two speakers, using commendable videos, gave us a good account of their techniques, surgical techniques of scleral fixation of IOLs. In conclusion, I'm very, very grateful to all the speakers from Sri Lanka for these very interesting talks, bringing variety to this symposium to make it very interesting. And finally, I would like to thank the organizing committee of the All India Ophthalmological Society, as well as the organizing committee of the conference, to the 79th conference of the All India Ophthalmological Society, for giving us this opportunity to participate in this program today. We are looking forward to collaborating with the All India Ophthalmological Society in the future for academic programs, and I wish them, on behalf of the college, I wish them every success in their future endeavors. Thank you very much.